Sexual disorders are defined by a disruption in the sexual response cycle or the client experiencing pain through sexual intercourse. Paraphilic disorders are defined by fantasies, intense sexual urges, or behaviors that involve specific objects, situations, or activities. Similarities occur in both when the enjoyment of sexual intercourse has taken place. An individual that has a paraphilic disorder usually experiences a sexual disorder, while those with sexual disorders do not always experience paraphilic disorders. The DSM-5 states individuals experiencing sexual disorders can have several sexual disorders at the same time, while paraphilic disorders are more specialized. Sexual disorders have subtypes to help describe onset, etiologies, and interventions. Lifelong is described that the onset has occurred since their first sexual experience. Acquired applies to dysfunctions that occur over a period of time following normal sexual function. And generalized refers to certain types of stimulation, situations, or partners. Situational is sexual difficulties that occur with certain types of stimulation, situations, and partners. Paraphilic disorders are usually surrounding the idea that individuals present noxiousness and a potential to harm another, and it's considered criminal behavior, while sexual dysfunctions do not. The harm is caused by their body and not the individual. Externalizing disorders include ODD, CD, IED, and DMDD. ODD, or oppositional defiant disorder, is where the client is showing signs of argumentativeness, vindictiveness, defiance of parents, teachers, and others that are in charge. They push boundaries and they show active signs of rule breaking, like tantrums or using their anger and their irritability to drive their antisocial behavior. In the emotion, consistency, intention, and severity boxes to check, ODD checks all of them except severity. Treatment for this would include family therapy and individual therapy, helping to provide them tools to function as an adult. There is no comorbidity and no medication suggestions for this diagnosis. Conduct disorder is where the onset is usually by age 10, and there are signs of fights, physical cruelty, violence, threats, property damage, fire setting, robbery, sexual corrosion. Conduct disorder checks all the boxes of emotion, consistency, intention, and severity. The severity goes into a level where they are violating others, and this could develop into antisocial personality disorder if it is left untreated. Treatments for CD would include behavioral modification, parent training, individual therapy, or family therapy. Medications aren't usually recommended for this diagnosis. Intermittent explosive disorder is where an individual is hitting, kicking, screaming, and throwing tantrums. They check the emotion and the intention box, but do not check the severity or the consistency boxes, since most of the episodes don't last longer than an hour. 13 years of age is usually the onset, and it is more than likely a lifelong condition unless treated, because some may brush it off as side of like puberty or hormone driven, and they never seek treatment. If treatment is sought, behavioral intervention and family therapy is recommended. Unlike the other conditions, treatment of SSRIs or other prescribed medications can be used or be helpful with this diagnosis. DMDD checks the emotion and the consistency boxes. The client experiences negative emotions, irritability, anger, and sadness. And only if the outbursts are intermittent does it really check the consistency box. But psychotherapy is the best form of treatment, and medications are not recommended. In treating a client with this diagnosis, It's really important to watch to see if this behavior could be based on their home life or their season of life. In all of these externalizing disorders, it is incredibly important to know the difference to help families watch for the 4 areas of emotion: intention, consistency, and severity, but to also deal with them individually and not depend on just the treatment of the medication, especially if it could do more harm than good, like with most of these disorders. While these disorders are external based, they usually do more harm to family members or those around them. But we cannot forget that the individual may be battling or dealing with something internal, causing the external disorder or external response. Substance abuse can be described as symptoms such as the acronym TIME to cut down POW, and 2 of more of the criteria is required. The T is time spent, C is cravings, U is unable to stop, T is tolerance, D is dangerous use, O is others affected, W is withdrawal, and N is neglecting roles. P is for physical or psychological problems, A is for activities, L is for larger amounts or longer use. Substance abuse can vary depending on the substance used, but it must exhibit at least 2 or more of the symptoms from the Time to Cut Down POW acronym given in the video. The specifiers that are used in the DSM-5 is in early remission and sustained remission, maintenance therapy, or in a controlled environment. The video of mnemonics of addiction and substance abuse stated that the 3 reapers could help us identify if addiction was still present through repeated use, positive reinforcers, and negative repercussions. If these are present, as a clinician, it would be wise to determine this by case, depending on the substance or the addiction, and encourage group therapy or individual therapy. If the specifier is severe and the substance is a drug, rehab or hospitalization may benefit their path to sobriety. The video also recommends that motivational interviewing is a great form or a great way to get a range of where the client is and how to help them work towards finding a path to sobriety. But like the video says, it is important to channel the lost pastime with something positive and making sure that they have community and support while trying to obtain sobriety. Thank you so much. Have a great week.